All right, Adam, we're going to talk about chest x-rays,
Ready.
which is really, a topic near and dear to my heart. It's something that, we get a few of in the emergency department.
Yeah, a couple here or there.
Here and there. And the question always comes up, why do we care so much about chest x-rays? Aren't they old-fashioned technology? People are like, I can't really see anything on them anyway.
I'm ordering CTs on everybody anyway.
I mean, it seems like that in our shop anyway. But the reality of it is that chest x-rays are still the most common radiographic study that we get in the ED. And if you think about it, that makes sense because, the obvious ones, chest pain, shortness of breath, of course we're going to get a chest x-ray. But it seems like we get a chest x-ray for everything. Someone comes in with a stroke, we get an x-ray. Someone comes in, they twisted their knee, we end up getting a chest x-ray. And so we order a lot of chest x-rays in the ED. And if you think about it, there's some really valuable real estate in the chest.
Yeah, there's a lot of information there.
Yeah, there's a lot of information. The heart, the lungs, the great vessels, all things that when things go bad can kill a patient. And in a lot of places in the country, you're the person making that call. And sometimes the seconds and the minutes count. Yeah. And so you may not have time to get an official read if that's even an option for you.
Yeah, I feel like I get my CT scan reads back before my chest x-ray.
I know, which is really sad, but yeah, it seems like that. And then the other thing is that a lot of radiology, new radiologists are not nearly as comfortable reading plain film anymore. And so a lot of it comes down to us. Sometimes it's pretty obvious. I don't know, what do you think of this one?
Something going on in that left chest right there.
There is. Yeah, nipple rings. It's definitely the nipple rings. Yeah, obviously a huge pneumothorax. And so this one, again, pretty obvious. Sometimes it's not so obvious. What do you think of this one?
There's a lot on the picture, but I feel like I'm not seeing what you're trying to point out.
Yeah, this one's tough. There's a lot going on. This patient has some underlying lung disease.
Yeah.
This was a case from early in my attending career. This woman came in respiratory distress. We intubated her. And then about 5 minutes later, she coded.
Oh, wow.
And the answer's on the film. And if you look very closely, she has findings of a pneumothorax on a supine patient. So again, sometimes it's obvious, a lot of times it's not.
Yeah.
And so we're going to look at a case to sort of start us off. This case has really stuck with me through the years. It happened pretty early in my attending career again. And this was a trauma activation. This woman came in.
Okay.
It was about 6:30 in the morning. She was 24. And unfortunately, she had been pretty heavily assaulted by her husband. She was beaten pretty severely about the head and the neck, came in GCS 3. And so per ATLS protocol, we intubated her on arrival. And this was her x-ray. And so right around change of shift, I had signed out to the incoming attending. I was sitting on the side, finishing my charts for the night. And the EMS worker came up to me and was like, hey, I heard she's going to the operating room. And I was like, wow, that was pretty fast. That was just like 10 minutes ago. And I assumed it was for her head because that was really, the only sign of trauma. And she's like, yeah, they're saying she has a diaphragm rupture, that her NG tube's up in her chest and she has all this fluid and everything. And I was like, that's kind of weird.
Yeah. I mean, you don't even see the left lung or the heart, but you can certainly see that NG tube up there.
Yeah, so it certainly looks like it's up in the chest, right?
Yeah.
And so I pull up the x-ray and I'm looking at this, I'm like, something is not right here.
Yeah.
Clinically this isn't making sense, the radiograph isn't making sense. So I walk back in the room and they were indeed packing her up to take her to the operating room. And I was like, look, she's stable, let's take a time out.
Yeah.
And sort of assess things. And if you look closely at this x-ray, you'll notice one glaring thing, and that is that she's right mainstem.
Ah, there it is.
There it is. And so she dropped her left lung.
Tubbs, tell me you pulled the ET tube back.
I did actually pull the ET tube back. And so, and this was her 5 minutes later.
Okay.
So you can see she's nicely reinflating. Her NG tube is in fact below the diaphragm.
Right there. Okay.
And so we called a big timeout in the room, and I was like, look, she's stable. Let's get her over her head CT, which is what she needed. And in fact, she did end up going to the operating room for her decompressive hemicranie, for her massive subdural.
That would have been delayed a lot while they were doing that thoracotomy.
Yeah, exactly. I do think she probably would have died on the table, honestly, because she was herniating. And so it really nicely highlights that, chest x-rays do matter.
Yeah.
And, this is sort of a key concept that Adam has heard me say ad nauseum throughout his time with me, is that you need to be systematic.
Yeah.
And you can't get happy eyes. This was obviously a very emotionally charged case. People, wanted to do something, and so they saw this obvious x-ray finding and they jumped on it. So
you got to read your own films, right?
And actually, I do say that once in a while. Yes. Everyone at Brown knows you need to read your own films.
Yeah.
At least when you're working with me. And so, looking at our case on the left, this is complete atelectasis with volume loss. It's retractive. It pulls stuff away from that side.
Now I can see it.
Effusions, on the right, has really, sort of deviated everything away from that side. So our objectives today are pretty simple. We're going to talk about sort of key factors in assessing adequacy.
Okay.
In chest x-rays, we're going to talk about a systematic way to image them.
There it is.
There it is. And then we're going to look at some illustrative cases highlighting the importance.
Perfect.
All right. This was actually Adam during his early residency career.
Definitely.
Definitely. And so how do we read these things? And so I like to say that chest x-rays are like the medical Rorschach drawing. And so you can sort of look at them and be like, yeah, I think there's pneumonia, or yeah, maybe they're a little wet. Really, it's whatever it takes to get them admitted to the hospital sometimes. But the reality of it is that even though they're black and white studies, it really is shades of gray.
Yeah.
And you get an x-ray like this, what do you think of that?
There's a lot going on there. I can't wait to see what the radiology read is.
Yeah, so it's super helpful.
Okay.
So here it is. Interstitial prominence, bilateral airspace opacities. At the end of the day, recommend clinical correlation, right? I feel like they can say that in their sleep. And so at the end of the day, it's like, yeah, thanks. Thanks for nothing. And the problem is, though, is that chest x-rays are really hard.
Yeah.
They're a difficult study to interpret. There's a lot of things they factor into it. And the radiologists actually have it really hard. I like to knock on them a lot, but they really do have a hard job. And I like to take a minute to sort of look at this idea. Like I said, even though they're black and white studies, it really is shades of gray. And I like to say that we interpret chest x-rays, not read them. Because when you say you read something, you imply that there's like one meaning to it.
Yeah.
And that it's sort of cut and dry. And that's certainly not the case here. Really what we're doing is we're taking elements of the history and the physical exam, which we as clinicians have access to, and we're using that to sort of mold our interpretation of that x-ray.
Okay.
Just like we try not to call interpreters translators, because they're not just translating word for word what a patient is saying, they're really pulling in cultural cues and differences to interpret what they're saying into an appropriate context. Okay. So let's approach it like that. We're going to interpret our chest x-rays. I like to start with a little bit of anatomy just to...
You're going to quiz me on the anatomy.
I am actually going to quiz you on the anatomy. And so these are lungs.
Okay,
right?
I got that. Okay.
Excellent. So your right lung, again, pretty basic, but it's worth reviewing. Your right lung has 3 lobes, so an upper, middle, and lower lobe, which means it has 2 fissures or interfaces between them. And so you have a horizontal or minor fissure, and then an oblique or major fissure.
Okay.
And then on the left side, we only have 2 lobes, an upper and a lower, and so therefore we only have 1 fissure, which is also an oblique.
Okay.
Looking at it from the side, this is the right lung. You can see there's upper lobe, middle lobe, and right lower lobe.
Okay.
And I think this is helpful to sort of visualize because it highlights the fact that we have overlapping structures here, which is a problem in plain radiography because we're looking at a 2D image of a 3D structure. And so the question always comes up when you see something in the lower lung fields, is that a middle lobe process? Is that a right lower lobe process? And as we go on, we'll sort of talk about ways to suss that out.
I think this highlights more than anything the importance of getting that lateral when you're able to.
Yeah, absolutely. I like to say that the laterals or the PA view is really just the tip of the iceberg and that there's a ton of information that can hide on the lateral. So absolutely. Whenever possible, I definitely want to see a lateral.
That makes sense.
Lot going on with this x-ray. I like it though because it very nicely shows us that horizontal fissure here. This is a very edematous overloaded patient, so it's pretty obvious.
Even I can see that.
Okay, excellent. Looking at it from the side, again, it sort of nicely shows us there's our horizontal fissure and our oblique fissure.
Okay.
And if you trace that oblique fissure down, you can see that it merges with this right hemidiaphragm.
There you go.
So that's your right major fissure.
Really hides inside that heart. You gotta look. Actually, I have to look for it in order to see it.
You do. Yeah, these can be pretty subtle. Moving on to the Costophrenic angles, they really should be nice and sharp and distinct. If you're seeing blunting there or like a little meniscus effect, that either means most commonly it's going to be pleural fluid or scarring from an old lung infection.
Okay.
You see a case like this again. There's a little bit of blunting. Or almost like a little meniscus effect down there.
Yeah, it's not quite as crisp.
Exactly. You can see on the other side, it forms a much sharper angle there. So there's a little right-sided effusion. And it drives me a little bit crazy because radiologists will often refer to this as a trace pleural effusion. And I don't like that because by the time you're seeing this on the PA view, there's at least a couple hundred cc's, at least 100, if not more cc's in that posterior costophrenic sulcus.
It's a little more than trace.
It's a little bit more than trace to me is like 10 cc's. So, so just keep an eye out for
Okay.
that. Moving on to the heart. On the PA view, the heart should never be more than half the width of the thorax at its widest point. Here's a nice normal heart. This is a PA view. You can see there's the hemithorax at its widest point. Looking at this one, though, something going on here, right?
Yeah, that heart's pretty big.
That's a big heart.
Yeah.
So if you look at it, there it is at its widest point. There's the hemithorax at its widest point. So pretty big.
Yeah.
And so it turns out that it's not just size that matters.
Okay.
And so shape comes into this. And so this woman was a 65-year-old woman. She came in complaining of pleuritic chest pain, shortness of breath, and she ended up getting admitted to our chest pain obs unit for an ACS rule out. And the nurse over there, I was in charge of the unit that day, I was covering it, and the nurse called over and she's like, hey, I know you haven't seen this patient, but I'm a little bit worried about her. She's still complaining of this, really pleuritic chest pain. She's a little tacky. And so I was like, all right, well, let's get a dimer.
Yeah.
And so we got a dimer, and of course it was through the roof. And so we scanned her, and she did not, in fact, actually have a PE, but what she did have was a massive pericardial effusion.
Oh, wow. Okay, well, are these the same patient right there?
Yeah, so this was her a year ago on the right.
Yeah, clearly the heart is huge. And if you didn't look at the old one, you wouldn't have necessarily known that was acute. But it seems oddly shaped as well.
Exactly.
Yeah.
And so this is very bulbous or almost like boot shaped. And I like to think about it, if you take a water balloon and sort of bob it on the table, let it sort of sink down, that's sort of what happens here. The pericardium sort of like splays out.
That makes sense.
And so, this was her echo. So again, pretty big sized pericardial effusion. And unfortunately, this was her new diagnosis of breast cancer with an malignant effusion. So
wow.
So again, a couple concepts. It's not just size that matters, but shape.
Okay.
And also, it highlights the importance of looking at priors.
Oh yeah, no,
Which is something that's drilled into radiologists from like day one in residency. They're always taught to look at priors, so it's helpful for us as well.
Yeah, the radiologist, I feel like it auto-populates on their screen when you go back there, and doesn't necessarily do it with ours. So you have to make a conscious effort to do it.
It's a little bit more work for us, like most things in medicine. But yeah, it's worth doing.
Yeah, definitely.
Okay, looking at heart borders. So structures that sort of form the right heart border. There's your right atrium. There's your left ventricle. Your right ventricle sits right behind your sternum, so we don't typically see that on the PA view. Looking at it from the side, there's that RV sitting behind the sternum. Our left atria sits behind. So again, we typically don't see that on the PA view. Looking at the aorta, it should sort of come up and then make that nice turn. That's your aortic knob.
Okay.
And then as it comes down, it really should parallel your thoracic vertebrae.
Okay.
This, again, a lot going on in this patient. This is a guy with really bad bullous emphysema, which is what your eye is sort of drawn to up on the right. But I picked this one because it very nicely shows this anatomic area, which they refer to as the AP window or the aorticopulmonary window. And it's just that interface between the aortic knob and the pulmonary vasculature. We look for that, particularly in cases of things like aortic trauma or sometimes dissection, because with those cases, you will often lose that AP window.
Okay.
So moving into the mediastinum, there's our trachea, there's our right and left mainstem. You'll notice the right mainstem takes off at a much steeper angle, which is why the majority of airway-formed bodies end up there.
Okay. Or when you right mainstem. Like
or when you're right mainstem. Yeah, exactly. Not that that ever happens, but looking at it from the side, this is sort of a danger zone, and they call this the retrosternal clear space.
Okay.
And you should see aerated lung sitting above the heart in that anterior mediastinal space. There was a famous radiologist named Lucy Squire, and she sort of wrote the book on how to read x-rays. And she coined this term, great white in the 4 Ts.
Okay.
And that's for things that show up in that anterior mediastinal space. And so the things, great white is the heart.
Okay.
And then the 4 Ts are things like thymus or thymoma.
Okay.
Teratomas or other germ cell tumors, thyroid, so you can get a big substernal goiter sometimes.
Okay.
And then the last one is terrible lymphoma, which is a stretch. I didn't make this up, I swear, but that's the 4th T. And when we look at a case like this is a 28-year-old
Okay.
who came in, and he actually was a hospital employee, and he came in with a syncopal episode.
Okay.
And the story was he had been on call the night before. He was rounding in the ICU, hadn't eaten or drank anything. Was seen by one of the residents who's like, yeah, I think he was just like dehydrated. He'd been on his feet for hours,
That would
very
make sense,
plausible.
yeah.
Yeah. She's like, EKG looked okay, his vital signs look okay, and giving him some fluids. I think he can probably go home. So I was like, it sounds totally reasonable. I walk in the room and, your spidey sense goes off. And I'm looking at this guy and he's like gray, his color was terrible, and he was covered in these excoriations.
That doesn't sound like dehydration.
It doesn't sound like
Yeah.
dehydration. And I'm like, what's going on with that? And he's like, I don't know. My primary and I have worked it up. It's not my liver. It's not. He's like, I even treated myself for scabies. It's not that. I'm like, you losing any weight? He's like, yeah.
Ooh.
I'm like, you having night sweats? He's like, yeah. This was a physician. And I was like, come on. He's like, yeah, I know. I'm like, let's at least get a chest X-ray on this guy.
Let's take a look.
So we get an X-ray.
Okay. Yeah, I mean, looking at that right above his heart, I mean, you don't quite see that nice aeration like before.
Yeah. So a little bit, you see some aerated along here.
Yeah,
You see the sort of dense consolidation.
Yeah,
up here,
it's
right?
definitely different than before.
And then you look at his PA, and sure enough,
Yeah.
he's got this huge anterior mediastinal mass here. This ended up being his lymphoma.
Yeah.
He thankfully did fine with treatment, but this is sort of a danger zone. And the reason why I say that is, if you've ever had a chest X-ray taken yourself or watched someone get a chest X-ray, the position you're supposed to be in with the lateral is with your arm straight up
yeah.
to get your arm waddle out of the way of that anterior mediastinal space.
Yeah.
But you think about it, our sick, older patients, they sort of drape their arms over the cassette. And so, grandma's...
Yeah. The radiology techs do their best, but it's not always adequate.
Yeah, it's often limited. And so you can hide stuff there.
Yeah.
And so really want to pay careful attention to that. All right, so how do we interpret these things?
There it is.
There it is. You're going to hear this a lot during this course. So you need to be systematic.
Yeah.
And so for chest X-rays, there's a few things that go into this.
Okay.
The first thing is you want to make sure that it's the right patient and it's the right study.
Yeah.
And this sounds sort of silly, but with digital radiography especially, it's very easy to pull up the wrong study.
And we've all done it. I mean,
We've
let's be
all done
honest. Yeah.
I almost got burned on this a couple of years ago. A guy came in, sounded terrible, was satting like 88%. His lung sounded terrible. And it was like September 12th. And was seen by a resident who was like, yeah, his chest X-ray looks clear. And I'm like, there's no way this guy's chest X-ray looks clear. And they're like, yeah, they're reading his chest X-ray is clear. First of all, didn't look at their own film, so that was a problem. But I went and looked, and it was from September 12th of the year prior. And he just hadn't gotten his X-ray yet. And so we got his X-ray, and sure enough, he had multifocal pneumonia. Yeah. So you really want to make sure that it's the right study. The other thing is when sick patients come in, we tend to get serial chest X-rays.
Yeah.
Someone comes in respiratory distress, we get an X-ray. We intubate them, we get an X-ray. They drop their pressure, we get an X-ray. So even within the same visit, especially in sick patients, you can rack up multiple chest X-rays.
Yeah. It's really important to make sure you're looking at the right one.
Exactly. And like you said, we've all been
Yeah.
burned or nearly burned that way before. So look at the film markers. The next thing you want to do is make sure that left is really left. All right. Make sure this isn't, that they haven't flipped the films. Our image viewer had an issue about 10 years ago where it started randomly flipping X-rays. And someone almost got a wrong-sided chest tube because of it. So
Oh my God. You can't make this up.
you really
sometimes.
can't.
Yeah.
This is our job, right?
Yeah.
And so you really want to make sure that, left is really left.
Yeah.
And then the third thing, and this honestly is probably one of the most important things. So if you take nothing else out of this course, this is one of the key highlights, and that is evaluate the film technique.
Okay.
And what I mean by that is what position were they in when they shot the film? Were they upright or were they supine?
Okay.
Was it PA or AP? Because that will have huge implications on how we interpret that film.
And these are on all, like the radiology techs put whenever
They
do it,
should.
They should. Okay.
They should. That's part of like
Okay.
their protocol when they do that. So you should see that. And it really behooves you to look at it.
Yeah, no, absolutely.
And as we go through the chest X-ray sections, we'll talk about why this actually really matters.
Yeah.
Okay, the next thing is assessing adequacy. Do you feel adequate, Adam?
Most days.
Yeah. So there's a few things that go into adequacy in chest X-rays. And so the first is penetration, and then rotation, inspiration, and then what I like to say is completeness.
Okay.
So we want to make sure we see everything on the film. So when we look at penetration, what a lot of people don't realize is it's not a one-size-fits-all button.
Yeah.
So the radiology tech, they look at the patient and based on their body size and habitus and stuff, they dial up or down on the amount of juice that they give, the radiation. And most of the time they're really good and they get it right, but sometimes they don't.
Yeah.
And so sometimes they give them too much radiation, so that's an over-penetrated film, or sometimes not enough, so it's under-penetrated. Or, unfortunately, more commonly now, due to our ever-growing body habitus as a society, sometimes there's not enough juice. You know, they max it out and they're still under-penetrated.
Okay.
So the way that we look for that is we look for the lower thoracic vertebrae.
Okay.
And we should be able to see them through the heart.
Okay. Is this something you can correct with digital radiography a little bit?
So, yes and no.
I'm sorry, I'm scrolling the air. It says we go back and forth and up and down. Yeah.
So if the film is over-penetrated, you usually can.
Okay.
Because the data is there, it's captured.
Okay.
If they're under-penetrated, you can't.
Okay.
And sometimes you'll pull up and you'll see a really funky looking chest X-ray and you're like, what the heck is going on here? That's oftentimes because the tech has tried to post-process it
Okay.
and make it look better, but it doesn't work.
Yeah. Okay.
You don't want to see the thoracic vertebrae in great detail,
Okay.
like you would with a T-spine film.
Okay.
That would typically be over-penetrated, but you do want to be able to make out the outlines.
Let's see it.
So over-penetrated, the lung fields we call them burnt out. They're black. You can't really make out lung pathology. If they're under-penetrated, they look light. It makes everyone look sort of wet.
Okay.
And like we said, it can be corrected with digital radiography if it's over-penetrated, if it's under, you're out of luck.
Okay.
This is my PowerPoint manipulation to sort of show you approximately what it would look like. And so, you know, the case on the left, you can see those lungs, you can't make out any lung pathology. They're just burnt. And then the one on the right looks like they're volume overloaded.
Okay.
So look for that. The next thing we assess for is rotation.
Okay.
And again, this will have big impacts on the quality of the film. So ideally, you want to look at bony landmarks. And your clavicular heads, you want to identify those. And then the tip of the spinous process should be right in the middle of that space. When they're rotated, and we tend to see this more with portable films or AP films, because in those cases, the cassette is behind them. And, you know, you see the tech comes in and they jam that cassette in under them, and the patient's like off like this. The effect of that is that one side is going to expose differently than the other.
Yeah.
And it also tends to splay out the mediastinum.
Okay. I'm trying to think, like one part of their body is further away from the cassette.
Exactly.
Okay.
And so, and it doesn't take much to cause like a difference in the exposure. So this is a nice normal one. There's our clavicular heads. There's the tip of the spinous process.
Okay.
This one is rotated and it's an AP supine trauma patient. So looking at our film markers over here. First thing I see is that mediastinum looks huge.
Yeah.
And in a trauma patient, one of the things we worry about is a blunt aortic injury.
Yeah.
But then, so there's the clavicular heads, there's the tip of the spinous process, so it's very, you know, off center. So there's that big mediastinum. And then the other thing that I notice is that the left lung is just hazier, it's brighter than the right. So then which side do you think the pathology might be on?
This is a good quiz. I'm trying to like rotate myself and trying to imagine. I just don't know. Tell me.
Yeah, so it could be either, honestly. So most commonly when you see this difference in the lung exposure and it's hazier on that side, most often that's going to be a layering effusion or layering pneumothorax. And I'll show you some cases later about that. Or it could be a massive pneumo on the other side.
Yeah.
And so it can sort of go either ways, but much more commonly when you see that hazy lung field, it's because of a layering effusion in a supine patient. We don't use soft tissues to assess for rotation because your soft tissues are mobile.
Yeah.
And if you think about it, your trachea often sits more off to the right because the aortic arch sort of pushes it over. So it's naturally a little bit deviated over. The next thing is inspiration. And so we're feeling inspired here. So here's a case. This was a 38-year-old gentleman who came in, sort of a shady guy. He was actually in the courthouse waiting to be arraigned for something. And he was sitting on the bench and basically fell asleep. And the police brought him in because they were concerned that he passed out. And so he came in as a syncope patient. The nurses, you know, in triage ordered some protocol orders, including a chest x-ray because
we get chest x-rays on everybody.
And here's his x-ray.
It's not what I was expecting for syncope in a 38-year-old, but
Right.
yeah.
And he's not like an otherwise pretty healthy guy.
Yeah, both of his lung fields are pretty hazy.
Yeah. So pretty hazy.
Yeah.
His heart looks huge.
Yeah.
Right. Looking at the guy, he looked great.
Okay.
He's sitting there. He's like, yeah, I really don't want to go back to jail. I don't blame you.
Yeah.
But wasn't complaining of anything. His heart was
Yeah.
normal. His lungs sounded clear. His vitals were all normal. So this didn't make sense.
Yeah.
So this was him 20 minutes later.
What?
What magic did I do to fix this guy?
You are quite magical, but I have no idea what you did.
I told him to take a deep breath. So this is the effect of inspiration.
Yeah.
All right. And so when someone's incompletely inspired, everything sort of shrinks down. So it's going to make your lung markings more congested.
Yeah.
It's going to make your heart and mediastinum look bigger. Everything just gets sort of squished. So ideally, we take films in full inspiration. And the way that we look for that is we count the ribs.
Okay.
And so we do it on the right side. And on the right side, your 10th or 11th rib should intersect what we call this cardiophrenic sulcus. So where the heart and the diaphragm meet right there should be the 10th or 11th rib.
I do feel like that's sometimes the hardest thing for like our older patients, the timing and everything. So we just really got
or kids.
Oh yeah, good point.
You know, we'll talk about kids, later in the series, but yeah, trying to time it so that they're in full inspiration.
Yeah.
Or someone in respiratory distress.
Yeah.
Like, it can be challenging. And that's just one of the inherent problems with chest x-rays is they're often just limited.
Yeah.
So sort of the last thing that we talk about is completeness. So how do we put all the pieces together? You want to make sure that you're able to see everything on the film. So here, clearly, we've cut off, the costophrenic angles here. Is it a big deal? Sometimes it is.
Yeah.
Sometimes stuff hides down there. So you want to make sure that it's complete. And along that line, similar to what you said earlier, ideally, you really should be getting a lateral chest x-ray as part of a chest x-ray series because there are a lot of things that only show up on the lateral. Sternal fractures. So sternal fractures are actually easier to see on a lateral chest x-ray than they are on an axial CT, which seems kind of crazy, but they tend to sort of hide between the slices. And so sternal fractures, small pleural effusions, small pneumonias, masses, that sort of stuff, they tend to hide on the lateral. So, which this case sort of really highlighted for me. This woman came in, she was 54, she came in an SVT. Very classic SVT. We actually broke her with some enhanced vagal maneuvers. She was feeling great. We got a chest x-ray because that's what we do. And here's her chest x-ray. What do you think of that?
Trying to be systematic here.
Appreciate that.
I'll be honest, I'm not really seeing much on the PA.
I didn't either.
Yeah.
Looked pretty good.
Yeah.
And that's what I told the lady. I'm like, yeah, your chest x-ray looks good. You're in this funny rhythm. You're out of it. It's pretty benign. We're going to send you home. And she's like, oh, thank God. I'm like, what's going on? She's like, I was actually supposed to go next week to get a repeat chest x-ray because I had pneumonia last month and my primary was really worried about it and wanted me to get a repeat x-ray. So I was like, oh, good news. I'll call your primary and let them know you don't need that x-ray. So I call him and I'm like, hey, Bill, I got your patient here. She came in an SVT. She broke. She's doing well. Her chest x-ray looked clear. I know you're worried about it. And he's like, oh, that's great news. He's like, yeah, I was really worried about her x-ray. And then he's like, wait a minute, Bob. He's like, did you get a lateral? And I was like, no, we just got an AP because she was in our critical care bay. He's like, do me a favor, shoot a lateral and call me back because her pneumonia only showed up on the lateral. Wah, wah, wah. So
okay, there it is.
there it is. And so you see this sort of consolidation right here. Turns out this is her entire right middle lobe that's consolidated.
It's crazy you didn't see it at all on the PA.
At all. Not at all.
Yeah.
And so, going back to look at it, even in retrospect.
Even with the history, I'm still looking for it. Yeah.
And again, this is where, 2D structures, 2D image trying to image a 3D structure, there's limitations to it. And why you always, if you can, want to get a lateral. And so this was her entire right middle lobe. And so then the question is, why did she drop her right middle lobe? We scanned her and sure enough, she had an endobronchial lesion there.
Yeah.
So this was her new diagnosis of cancer. So again, just highlights how important this really is.
Yeah.
All right, so next steps. So we've already sort of looked at the image. We made sure it's the right patient, the right chest x-ray that we're looking at. We've assessed adequacy. Now we actually need to interpret these. And so there's different approaches out there.
Okay.
And you'll read these in the textbooks, you'll see them taught. One is the geographic approach.
Okay.
I remember learning about this in medical school, where you either start at the outside and work your way in, or start on the inside and work your way out. The problem with this is, especially when you see something obvious, it's human nature, you stop.
Yeah.
And so you're not actually getting the whole picture.
Okay.
The second approach, which is what I think a lot of us in emergency medicine do in practice, is
Yeah.
the targeted approach.
We're looking for something.
Exactly.
We look for that thing.
So someone comes in, fever and a cough, what are you looking for?
Pneumonia.
Pneumonia. So you get the x-ray and
Yeah.
for the pneumonia. You miss stuff that way.
Okay.
Again, particularly if there's an obvious finding. You miss the other finding. And so the approach that I like and the one that I teach all the time is the ABCs. And for chest x-rays, what that means is airway bones, cardiomediastinum, diaphragms. E is for everything else. So lines, tubes, foreign bodies, all that
Okay.
stuff, free air under the diaphragm. And then F is for fields or lung fields. And that's why I like this so much, is because it puts the lungs last.
Yeah. I feel like it's easy to get happy eyes when you see something in the lungs.
Super easy. It's human nature. When you
Yeah.
put that chest x-ray up, you get these big lungs staring in the face, you're going to focus on that. I am just as guilty as everyone else. As evidenced by this case,
Okay.
early, again, in my attending career, to my shame, this patient came in, 21-year-old male, spastic quadriplegic, nonverbal, he had severe developmental delay. Had a known seizure disorder, but he was coming in with multiple recurrent seizures, which was out of character. And he actually seized and then vomited right in front of us in the ED.
Okay.
And you could just hear the aspiration. I mean, it was bad. And he was, tachycardic, he was hypoxic, he was tachypnic. And so we got an x-ray, and sure enough,
Well, there's the aspiration.
there's the aspiration, right?
Maybe his heart's a little big.
Maybe
but-
a little bit big. It is an AP film, so it's
Yeah.
going to artificially magnify that a little bit.
Okay.
And he's, not taking the world's best breath.
Yeah.
Again, sort of limited there. But yeah, big, obvious sort of
We found what we were looking for.
We found
Yeah.
what we were looking for. I saw the aspiration, so we admitted him.
Yeah.
And he was there with his mom, who took incredible care of this kid. I
Yeah.
mean, she was just unbelievable. And she kept coming out of the room, and she's like, something's wrong with my son. I know him well. There's just something, he's agitated, something's not right with him. And I sort of patted her on the shoulder. I'm like, oh, he's got this aspiration pneumonia, he's hypoxic, and, we're admitting him, and go back in your room. And she kept coming out. And then about an hour later, the radiology attending came out.
Which never a good sign.
Never a good sign. They stumble out of the room. They're, like Dracula in the sunlight,
Yeah.
And he comes over and he's like, Bob, what's going on with this guy? I'm like, well, he aspirated.
Yeah.
He's like, yeah, I haven't seen any post-reductions come by my desk.
Oh, that left shoulder right there.
Yeah. So there it is.
Oh.
So when he seized, he popped his shoulder out, and I let this poor nonverbal kid sit there with his shoulder out for hours because I got happy eyes.
Yeah.
And so it happens. You just really need to train yourself to be systematic.
Yeah. No, I remember a case where it was a trauma and we diagnosed the pneumothorax, but completely missed the clavicle fracture.
Oh, yeah.
Not that ended up being clinically significant, but it's still, this patient was sat there in pain, moving her arm and totally undiagnosed.
And this happens all the time. I have one case in my series, a trauma patient came in, pretty large, intoxicated man who fell down the steps. And, the initial trauma x-ray was a supine, his mediastinum looked wide. And so, the radiology read was, recommend upright chest x-ray when clinically appropriate to clear the mediastinum. And so you see the timestamps a couple hours later, he got his upright chest x-ray, his mediastinum's still wide.
Okay.
So they recommended a CT to look at his aorta. So hour went by, he got his CT. This was on the overnight, got read as normal. Great. He's sobering up. They're waiting for, a reevaluation in the morning. And then at 6:30 in the morning, when the radiology attending comes in, there's a discrepancy that comes in.
No.
And the guy's shoulder was out.
Oh, yeah.
And you can see it on his initial one, his upright one, on his CT, and everyone just missed it because they got
Yeah.
so it happens. So bringing it home, sort of to summarize, 4 things go into adequacy.
Okay.
So penetration, inspiration, rotation, and completeness.
Okay.
You got to pay careful attention to that film technique. Were they upright? Were they supine? And remember to be systematic. Don't get happy eyes.
Yeah.